Back in 2020 to 2021, we started implementing our high sensitivity troponin assay into our health system. And as we did that, we had a group of emergency physicians, including Seth and others, and partners from our lab, as well as our cardiology teams. And so Ben Cook here and Jim McCord are part of our lab and cardiology teams. And we created an algorithm that we use to roll out the high sensitivity troponin, essentially using a 0-1 algorithm that many people, may have heard other institutions doing or maybe doing themselves. And I should mention this was supported by funding from Beckman Coulter, who provided an investigator initiative award to the health system. So we did do that, and all of us have had some consulting roles with Beckman over the last year. Um, but I think a lot of you know this already, that high sensitivity troponin allows for more precise quantification around diagnostic thresholds for MI. And in Europe, there's been a decent amount of work before we published this around 0-1 hour rule out protocols, where you use either the 0 hour or the delta between 0 and 1 hours to potentially rule out patients for MI and send them safely home. And so we called our project Race It, and we designed it as a real world pragmatic design to compare the two strategies of a more traditional approach of ruling out MI at 0 and 3 hours versus the high sense rapid rule out protocol with 0-1 hour values of cardiac troponin. And I'll show you kind of the details of how we design that. So standard care, you would have any high sensitivity troponin. Well, actually, what we did is we ran the high sense assay for patients, but we didn't report the values below the 99th percentile to the clinicians under the standard of care. And one thing to note is that within our system, and we still use the Beckman assay, which is a cardiac troponin I. So these values, depending on your specific assay, whether you use Abbott or Roche or Siemens, et cetera, the exact values that may be appropriate to your own protocols are going to vary, sometimes by a decent amount. But what we chose was that a high sense troponin I less than 4 at 0 hours ruled out a patient. So that patient was eligible for discharge without further testing. And then we did have within the 0-1 hour, if someone had a troponin of 4 but had a low delta, so their second troponin did not go above 7, they also would be ruled out. And then if patients had other troponin values, they would go into a bucket where we would consider their further testing based on a HERE score. So it looks like this didn't come out quite like I wanted, but essentially in that first bucket, so if they ruled out with the 0 hour troponin, they had a very low 0 hour troponin, or they had a very low delta, they ruled out and did not require application of a HERE score. However, if they fail into this intermediate bucket where they had some abnormal troponin values but less than the 99th percentile, then they would have a HERE score applied, and if it was less than 4, they were eligible for discharge without further testing. If it was 4 or greater, then we would consider further testing in the observation unit for further risk stratification. And I'll show you all some of the numbers in a bit of what actually happened in terms of testing. The way we did what's called a stepped wedge design, where within our 9 EDs at the time, we rolled this out in an incremental fashion. So we randomized the order of which it was rolled out. And so we would collect data on our kind of standard of care protocol. Then we'd have a period of implementation where medical directors or others at those sites would inform everyone of the new protocol and help make sure people were aware of it. And then After that, we would collect data on the post-implementation when patients were using or providers were using the RACIT protocol. So we did that across the EDs. So in the end, we collected a lot of data on the pre and a lot of data on the post. Um, just for the purpose of the study, because we wanted to focus on patients that the new high sensitivity values mattered, we only included patients that had high sensitivity values below the 99th percentile. So in case of the Beckman, that was below 19 nanograms per liter. And we excluded a lot of the high risk patients like ST elevation, patients with trauma, et cetera. Now, the main thing we looked for the outcome was, did a patient have a safe discharge, meaning that they were discharged from the ED and they did not have an MI or all-cause death at 30 days. And so we used both EPIC data, but then we also cross-referenced with state of Michigan information exchange data and the National Death Index to track whether patients had any deaths. So we actually weren't able to collect all the outcome data until almost a year after we finished including patients in the trial because of the needs to reference the death data outcomes. Then we collected all kinds of data on revascularization, cost, additional testing, et cetera. So in the end, we had 32,000 patients that were included in the data analysis. Of those, 13,000 received standard of care, and approximately 19,000 received the accelerated protocol. And we ended up having slightly higher admission rates, unadjusted, slightly higher admission rates to the hospital under the accelerated protocol. And we also had lower rates of discharge from the EDR observation, and ultimately lower rates of discharge from the ED, 58% in the accelerated arm and 59.8% standard of care. Now, because of the design of this study and because it overlapped with COVID, you can't really use the unadjusted rates as a good estimate of the effect of the protocol. So that the real primary analysis adjusted for the design of the trial, the sites, and time, as well as a few other covariates. But time being an important one in this case because we did overlap this period of data collection with COVID. So in the end, this is an idea of like the patient population, pretty typical for cardiac evaluation. We'll mention though that we did not specify that patients had to have chest pain as a chief complaint in this. So the definition of who was in was if the clinician suspected that you might have ACS by ordering EKG, serial troponins, that was the definition of who was included for the most part. So a lot of patients had, I'll show you the chief complaints that made up most of the cohort. We'll note that in the rapid rule out, at the very bottom there, you'll see the rapid rule out cohort had almost double the number of cases of COVID-19. So it certainly affected that cohort a bit. Here's the chief complaint. So chest pain was certainly the most common chief complaint, but you can see shortness of breath, COVID, abdominal pain, dizziness, et cetera, all the different reasons why we order cardiac troponins all the time, in EDs. And so certainly when we presented this to some cardiology reviewers, they were a little surprised at the proportion of complaints that had cardiac evaluations, but I think we're all familiar with that. And this is the main outcome. So our pre-planned main outcome was looking at discharge rates difference. And again, if they had an MI or they had death, then they were not considered to have a safe discharge. And in the end, there was no statistically significant difference in rates of discharge safely between the two groups. And then we did a sensitivity analysis excluding for COVID-19 patients. That too had adjusted odds ratio 1.14, suggesting that there may have been an increased chance of safe discharge excluding the COVID, although that was not our primary analysis. That was a sensitivity analysis we did. And then I think one interesting thing, though, to point out in this is that when we break it down by site, and granted, there's some limitations to this because of the design of the trial, but I think it fits with what our clinicians are seeing is that if you apply this protocol to lower risk populations, you tend to increase the number of patients you discharge from the ED without further testing. And you can see this is across some of our sites. So our Fairlane ED in Dearborn in general has patients with a lower comorbidity burden than, for instance, our downtown campus. And so they had a higher increase in discharge patients through the protocol, um, uh, despite it overlapping with COVID and whatnot. And that was true at a lot of our smaller, both our satellite EDs and then some of our other community hospitals. And then if you look at like our main hospital in Detroit, there was no substantial change or a decrease in hospital discharges, in our Allegiant site too. So there's some limitations to breaking out by site, but we seem to see a very clear signal that if you have a lower acuity population you're applying the protocol to, being able to detect a very low troponin at 0 hours increases the number of patients you can send home without further testing. Whereas at sicker populations, and you see this all the time with your CKD patients or patients with heart failure, et cetera, that they tend not to have normal high sensitivity troponins. They're going to have more intermediate level high sensitivity troponins, even though they may have no coronary disease causing their symptomatology. Other important things when we looked at MI and death, it was exact same rates between the accelerated protocol and the standard care protocol. And in adjusted analysis, there was no significant difference. That was true for all-cause death as well as cardiac death. We had a panel adjudicate the deaths. When we looked at MI, there was no significant difference in type 1 MI. We did have a higher rate of type 2 MIs affected in the accelerated protocol. These were very low rates overall, 0.13% in the accelerated protocol. And then low rates of revascularization and PI. I should mention that these additional outcomes were on discharged patients. So overall, very low rates of adverse events in discharged patients, in either protocol, but certainly seen with the accelerated protocol 0-1 rule out. And this is by sites showing how many patients were ruled out at 0 hours based on the ED site. And again, we had, our Henry Ford Hospital had only 32% of patients would rule out from that 0 hour troponin, meaning that they had a troponin less than 4. But some of our sites, like our Brownstown site or Fairlane or Sterling Heights had, rates as high as 60, 70, almost 80% being ruled out with that 0 hour troponin. So a lot has to do with, some could be related to provider choices, but I think a lot has to do with the comorbidity burden of the patients it was applied to. I mentioned too, we did an economic analysis. We have an economist named Shushan Yanagulian at Wayne State who performed economic analysis and we were able to get billing data from the hospital and all patients included. And in that analysis, there was really no significant difference using this kind of accelerated protocol compared to conventional. We hypothesized that, potentially, if you're detecting more troponin, more abnormal troponins, because you're detecting this like intermediate range, that we might see more cost associated with more testing, but that did not bear out in the trial. So it's pretty cost neutral, both overall, as well as in terms of hospital revenue. There's no significant difference between the new protocol and the old. And then also, we didn't have, we looked at whether patients were paying more. They were not paying more. It was cost neutral there as well. So our hypothesis that, you might do more testing because you're detecting more intermediate troponins by using high sense protocols did not bear out to show any difference in cost. There also didn't seem, now some of the European literature had demonstrated pretty substantial reductions in length of stay at EDs by using this kind of a protocol. And as you can imagine, if you can rule up patients out at 0 hours and send them home without further testing, theoretically you could reduce your length of stay. This did not bear out in this trial. Um, when we did a sub-analysis, though, of just looking at our lower acuity freestanding EDs, there did seem to be a modest reduction in length of stay in those EDs, which again may reflect that ability, that much higher rate of discharging people or at least having the potential to discharge people at 0 hours compared to having to apply 0 1 hour protocol. So we did, from looking at the safety endpoints of death and MI, we found the 0 1 hour strategy to be safe compared to standard of care, which was previously using a traditional 0 3 rule out protocol. And then it looks like the efficacy of these accelerated protocols is going to vary based on patient population. And we found, it'd be a great opportunity to kind of do a pragmatic trial within our institution. And that's a quick overview, and love to take any questions from the group.
Thanks, Jess. Yeah, I really appreciate you being able to present your work, and definitely relevant to our work too within Matic. I definitely have some questions, but I don't want to hog the scene. I don't know if there's others that want to pipe up.
I'll make one comment from a pragmatic standpoint. One thing that
Yeah.
we encountered through this is just the 0 1 3 sequence is operationally difficult. I don't know if we have data, maybe a question for Joe about when that 1 hour was often drawn, but we've been in discussions about whether we move to a 0 2 3 and then build in automatic cancellations and things, because it's a lot every time someone orders a troponin to get 3, when often we're just ordering it as a screening test we need 1, or to get a nurse to turn around and go draw 2 labs on one patient in an hour often just doesn't happen. When things are really busy. So just 2 comments, updates on how we're working with this right now, but we're still 0 1 3 as of today.
Yeah, and we looked at some of our data as to like how many patients would be discharged between the 0 1 hour based on that delta, and it's a pretty modest amount that would additionally benefit from that, that small time difference. So, agreeing with Seth that the 0 2 hour seems pretty reasonable. You're going to get, for any of these high sense protocols, like the most impact is going to be that 0 hour, and then whether you do 1 hour or 2 hours, I think whatever works best with your local shop. And agree, like for us, 2 hours seems a little bit more reasonable.
Joe, there's a question in the chat from Jason about any thoughts as to why you detect a difference in ED length of stay between these groups.
Yeah, I think it's hard to say for sure, but I think the biggest factor was the fact that we ran this during parts of COVID peaking in Michigan, and so a lot of length of stay data was really skewed because of that. But it'd be interesting to see what happens as people continue to apply this and study it in the U.S. I think there will be. I have to imagine it's particularly depending on what what your patient population looks like. You would see reductions in length of stay, and we certainly see this at the individual patient level. I have some patients that I would have kept around for 3 hour testing, but they're relatively low risk and they have a troponin less than 4, and I'm able to send that patient home pretty quickly. The other thing that makes it, I think that differs a lot between some of the European studies is, we looked at all comers that were applying cardiac troponin 4. There's a lot of the prior studies that showed reductions in length of stay, we're applying to more, a defined chest pain cohort that may not also be there with COPD and with, acute heart failure and with, being worked up for epigastric pain and getting a CT scan. So a little bit different than some of the prior research. Beth, do you have a question?
Well, I have a comment. I would say the main reason the length of stay didn't change is because we don't get alerted that all testing is back with the troponin tests. So
Mm-hmm.
there is a way in Haiku to get an alert. Doesn't work that great, to be quite honest. It just doesn't implement and work in your flow. I really honestly believe that's the main reason. So unless you're actually checking, which is hard to do in the higher acuity EDs because you get pulled to a code or something else, you come back and you're in Epic or whatever, your application may be, but for all of us, it's Epic. It looks like everything's back, then it's time to disposition your patient. Otherwise, you have to go and look for the result and find out that they meet for discharge now, and I don't actually have to wait. And I'm sure our different EDs had different ways of doing that. I mean, I know our nursing and tech staff would be putting comments and calling us, do I have to do the next one? But by that point, it was honestly the time or past the time to do it. So I think that's the main reason why we're not seeing improved times.
Yeah. I mean, I think and Joe, maybe that's a question for you. I'm sure you guys looked at just the chest pain chief complaint group, and maybe we didn't have enough numbers there, but I've got to believe, just from my experience, my favorite thing to say during my shift is less than 4 out the door. And I say it at least once or twice a shift. And, it's a really highly effective way to rapidly disposition patients without ambiguity. So I think exercising it in a way that providers know about it and can act on it more quickly. And that's one risk of the 1 hour too, because you miss the beat, the 1 hour gets drawn, and now the 1 hour comes back as you had a less than 4, and now your next one's, 8, and you're like, oh, well, let's get the 3 hour, and that doesn't happen that often, but it just, once you get more information, is more information. But I got to believe if you just look at chest pain patients, especially in lower risk populations, it's got to make a huge difference.
Yeah, no, agree. And we did look at the chest pain only patients, and it does seem to perform better across the board in that population, for sure.
And just to underscore, Joe, just for me to clarify, I think, and you tell me, but this rapid rollout with the high sensitivity troponin result less than 4, that's a discharge in your protocol without regard to the actual heart score too, right?
Yeah.
That's simply any patient with that initial test result goes home, which is really, I think, interesting to me that you skirt that additional step.
Yeah, in terms of some context, talking to other groups around the U.S. that have applied or studied their high sense protocols, I think we are a little bit of an outlier in terms of not requiring a HEAR or heart score for those very low value troponins. Now, 4 nanograms per liter on the Beckman assay is a pretty conservative number. Some groups have actually gone with less than 5 or less than 6 for that assay, and so there may be different cutoffs, but 4 is pretty conservative. Talking to Simon Mahler in the Atrium Wake Forest group, they also were early to roll out a protocol, a 0-2 protocol, 0 and 2 hour, but they still apply the HEAR score even for the very low troponin cohorts. So I think there's definitely some disagreement among institutions about, and people in this field. There are European guidelines that would agree with the rule out with very low troponins without application of other, HEAR or EDAX or other kind of risk stratification scores. But it's definitely a unique aspect of our protocol that we've been using.
That's awesome, Joe. I see that we're really at the top of the hour, and I don't want to continue the call past what we've scheduled it for, but